All right, everyone. It is 5-minute grace period. Thank you all for joining us. We are learning on the fly with me hosting a webinar. Good evening. I'm Aisha McCracken. I'm the founder of Ignite Healthcare Network. Thank you for joining us this evening for another installment of our webinar series, Igniting Leadership. Ignite Healthcare Network, a nonprofit, is a community of women executives, VCs, and entrepreneurs, all interested in shaping the future of healthcare. And what a better way to do that than to share these new insights and learnings to inspire innovation in your organizations. I've been really looking forward to this conversation, and I'm not the technically enabled one, but I'm driving this evening's webinar, so please excuse any glitches that may occur. So tonight, we have Dr. Kaveh Safevi joining us to discuss Accenture's new report, the 2022 Vision of Digital Health Technology. I'm going to introduce Kaveh. He is not only a physician, but also an attorney, and is a senior managing director at Accenture, where he's responsible for leading and developing and driving a growth strategy that differentiates Accenture's offerings for providers, health insurers, and public and private health systems across the globe. So he brings to us incredible experience in the depth and breadth of the work that he's doing, but also I think really an exciting opportunity to hear him describe their latest report, this new vision for digital health technology that really dives deeply into the kind of innovation from what I've seen, Kaveh, not just in the US, but also looking globally at all that has been going on, and how do we then assimilate, look at what's happening, and how does that inform what may be opportunities for future innovation domestically in the States as well. So we're delighted to have you. I'm going to turn the floor over to you and let you take it from here.
My pleasure. Good evening, everybody. Thanks for having me here, Aisha. I'd like to talk to you about a really interesting topic. It's a little complicated, and I want to take you through our technology vision for 2022. I hope we have a chance for a conversation afterwards. If the technology works, we may need to have you, I'll ask you, because with the group size, to raise your hand, and then maybe Aisha, you can unmute and we can actually get some dialogue going around what we're about to talk about. Let me put up some material here and let's begin our dialogue. So, as Alicia said, I have the privilege of being one of the global healthcare leaders at Accenture. I'm a physician by my original training and practice, but I'm very much a strong believer that we are at a point in our in society and in healthcare where some of these problems are too big to be solved by just well-meaning professionals, and that consistent with Accenture's brand promise, these are problems that require both human ingenuity and the promise of technology. Now, in that context, for the last 20 years, Accenture has been looking at technology and the nature of technology and its role in business and business strategy. And one of the things that's happened over that time period is a recognition that while technology used to be a capability, it's becoming increasingly indistinguishable from business strategy. In fact, last year, we made an observation based on the work that we're doing that increasingly leaders can no longer separate their technology strategy from their business strategy. They're effectively inseparable. The technology vision is something that we do every year. We've done it for 20 years. It comprises a combination of things. There's expert opinion, but then we also do surveys. We survey both citizens as well as business leaders. This year, we surveyed over 5,000 business leaders representing 22 industries in 35 countries, a large number of which are healthcare leaders. And one of the striking findings that comes out of the survey part of this work is this statistic: 97% of healthcare executives in our sample globally believe that continuous advances in technology are becoming more reliable than economic, political, or social trends in informing their organization's long-term strategy. Now, that's quite a statement. That is basically saying that the direction of travel, if you look out 5 or 10 years, is going to be more reliably shaped by what technology can do than other factors. And normally we don't think about it that way. But in fact, I think what we're going to talk about today, which is the metaverse continuum, is designed to illustrate the fact that what is possible is so different than the tools we had before that you can't really think about healthcare and healthcare delivery without taking these ideas into consideration. So that's the backdrop for the technology vision this year. And we describe it as the metaverse continuum because it's really not a discrete single technology or a single endpoint. In fact, to really do it service, we have to talk about what the metaverse is and what it really means. Let me place it in context. So we think about the internet in evolutionary phases. The initial phase was really about going to find information. The internet was a way for someone to find things out, go look for information and get it. The second evolution was really the ability to connect people together so they could create their own information, user-defined content, signified by things like Wikipedia in its early days, but we now are full of social media, which is really people defining and creating their own content. The phase of internet that began a decade ago was really about the internet allowing non-human objects to communicate directly with each other without human intermediation, otherwise known as the Internet of Things, which is now manifest itself in manufacturing and a whole bunch of other parts of society. The fourth phase, or this metaverse phase, is something that the term itself means, in some cases, it's used to mean everything or nothing because it's not really well understood. But I want to really define what the metaverse means the way we're using it. The word itself was first used in the 1990s in fiction to describe a virtual reality world. But it's a far more sophisticated concept today that has real technology underpinnings, which we're going to go into some detail. I'll describe the metaverse, and then I'm going to describe 4 kinds of technologies and 4 uses of technologies that create the building blocks for the metaverse. But it's really defined by 2 types of internet, what we describe as the internet of place and the internet of ownership. So what does the internet of place mean? Well, what it really means is the ability to represent the world in a virtual way or a non-physical way that has a few specific characteristics. One of the characteristics is that it is fundamentally interoperable, which means instead of going to each virtual world as a discrete experience, you can actually move from one to another and connect them to each other in a very simple way. For anyone who's experienced anything like an alt-space VR experience for work or for education or entertainment, and then maybe gone on to another site, you have to keep creating avatars of yourself. The concept of an interoperable metaverse would say, hey, the virtual identity that I created for this virtual application, I want it to be the same identity when I move from this application to that application. That's one of the concepts of interoperability. But another concept is this idea that multiple users can be in the same place at the same time. So rather than you choosing to go into a virtual place, the equivalent of you moving into a physical room, this would be the equivalent of being in Times Square, to use a New York City analogy. There are hundreds or millions of people that you don't know that are around you that you could bump into. So that's the second order of the concept of an Internet of Places. It's not only interoperable, but there are multiple users. The third concept of the metaverse ties to this concept of the Internet of Ownership. And that is the notion that we can actually transact things in a digital world, whether it's goods or services. And to do that, we have to have certain capabilities in place, capabilities that allow us to trust either the parties or trust the authenticity of the thing we are transacting. And that's what we mean by the Internet of Ownership. This idea that the provenance or the authenticity of the information, as well as the right to use or transact or act on that information, are all present. And when we have that, then we have the metaverse, which is this virtual world that is interoperable, that involves multiple parties where actual economic transactions can occur. That's the the highest order view of the metaverse. And I'm going to talk to you a little bit in some much more detail about what this means in healthcare through the building block examples. But our view is that this creates a whole set of opportunities for how healthcare is delivered, as well as how healthcare businesses operate, that we do not have at our disposal, but really allow us to solve some really important problems. And to give you one very specific one that we're struggling with today, we know for a fact that the demand for healthcare is outstripping the supply of people who are providing healthcare services. And if we continue on our current trajectory, demographics, economics, scientific innovation, all of these things are going to create a bigger mismatch. We're going to have to figure out how to provide services for people without requiring as many people to provide those services as we have in the past. That is going to require us to start thinking about some of these concepts that I've described in the metaverse, because without them, we're going to have a very serious problem of access. So keep that in the background as we talk a little bit more detail about some of the examples. There are 4 trends that are identified in our healthcare technology vision, and there's a lot of detail behind it. I'm not going to show you any more slides than the one you're looking at here right now, and I'm going to talk about them. But if you're interested, I would encourage you to go to Accenture.com and just type in Healthcare Technology Trends 2022, and you can get the full report. In fact, if you type in Technology Trends 2022, you can get the full multi-industry report that is sort of the parent for which each of the industries, including healthcare, sit underneath it. And it gives you a lot more detail about what we're talking about in terms of these trends. But let me start on the left side with trend number 1, which is what we describe as WebMe. WebMe really is comprised of 2 kinds of attributes. The first is the actual blending of a physical and a digital reality into a single reality. Now, we need a series of enabling technologies. One of them is mixed or augmented reality as part of doing that. But what's really critical to note is that the metaverse is not just a relabeling of virtual reality. In fact, one of the things we do a disservice is from an iconography perspective, and you saw that on the previous slide, when we often try to communicate the concept of metaverse in a picture, we show a set of virtual reality headsets. But the truth is that you don't have to be in a virtual reality headset to experience this concept of an integrated physical and digital world. In fact, you don't even have to be able to see to experience it. There are people right now working on technologies that take advantage of other senses, sense of touch, sense of hearing, sense of smell, as a way to create a blended physical and digital world. And what's critical there is a few concepts. The first one is the recognition that an immersive experience is different than reading about something. And we've known this from going before any kind of information technology was available. People know, for example, that being in a meeting is different than reading about a meeting. It leaves you with a different sense of ownership, a different sense of engagement, a different understanding. And what we are trying to do here is use information technology to get people to a different experience, one that is more engaging, more memorable, more impactful for many reasons, not just the reasons that are associated with entertainment, but I'll describe to you how healthcare is delivered in order to be able to give you some more specific examples. But that's a critical part. Second part is it allows us to solve for or juxtapose time, what happened before, what happened currently, and what happens in the future. All of these things are a critical part of the ability of technology to compress time. And it gives us a really interesting opportunity. So think about it in healthcare. If you think about the way healthcare is organized, if we're trying to provide some information to somebody in order to help them understand, for example, a surgery, think about something like informed consent. Today, it's very much a static communication of what's going to happen. But if I could, in fact, give someone a visual representation of everything that connects the complaints that they might have come to the office with, maybe it's an orthopedic procedure and you can look at the joints and mobility and their complaints, show them a little bit about what everything from the operating room to the incision might look like, and maybe a little bit about what their post-operative recovery is like to try to explain to them what functional efficacy might be. That's a very different kind of an interaction than simply talking to someone or giving them a piece of paper to read and then asking them if they understand what's going to happen to them. So this idea of juxtaposing time is really important. The other one is the ability to juxtapose physical locations. The analog world, you're either in one place or another place. In this blended physical digital world, you can bring two physical locations right next to each other. And when they're right next to each other, then you can begin to see, you can begin to learn, for example, from people that are in different rooms, but you need to know what they're doing at the same time. So that's what we're trying to solve for or address in this WebMD, is this ability to re-represent an experience, to make it immersive, but also to cross the boundaries of time and cross the boundaries of location. And our view is that there are many opportunities in healthcare where this makes certain things possible. And not only does it make healthcare better, but it might make healthcare more accessible, because it might allow us to reach people who today would have to have a physical interaction, because that's the only way we know how to communicate the healthcare experience, with one that is either all virtual or a blended physical virtual, but really solves for the access issue that a physical only world would limit. The second trend is what we call the programmable world. And this has really two principal attributes to it. The first one is the concept that technology is ambient, meaning it's present all the time, and we don't have to choose to actively interact with it to get the benefit of it. And the second part of it is that technology is actually implanted into the physical world that we live in, as opposed to it being something about keyboards and screens. Let's talk about the concept of ambient technology. Right now, the best examples of ambient technology that are going to have a material impact on healthcare might be the category of what is described as ambient listening. Ambient listening is technology that listens to our conversation and understands it in a way that it can capture structured concepts and then act on them. Why do we have doctors type? It's caused their productivity to go down by somewhere between 10 and 13% in the last decade and a half. Well, we do it for good reason. It's not a tool that's ideal, but we do it for good reason. We have been trying to capture that interaction in a structured way for a long time, because when we capture that interaction in a structured way, we can then act on it. We can do analytics on it. We can make workflow decisions on it. We can hit decision support tools up against the doctor's judgment. If all we wanted to do was have a transcript so another doctor could read it, we already knew how to do that. That's just typing and transcription. But that didn't give us the ability for any kind of machine computation. We knew that digitizing records was more than digital paper. It was about computation. So we caused people to stop their day and introduce structured information through a keyboard. We now have ambient listening. It's been developed. It's being deployed in real life in early examples. It's getting better. That will essentially be able to replace the doctor's keyboard activities. It doesn't substitute for a transcript, but what it does allow is a natural conversation. And if you want to see what this is like, if anyone has had an experience at a Forward Healthcare clinic, which is really a concierge primary care experience, part of the essence there is the doctor and the patient are having a conversation, and the technology is listening to the conversation, and it's listening for problems, medication lists, concepts in their past medical history, and then presenting them as discrete terms that a doctor would normally type in the medical record. In the Forward Healthcare experience, it's actually showing up on a screen so the doctor and the patient can see it, and they can actually validate it at the same time. But that's not where it ends. The other thing it does is it evokes a workflow. What I mean by that is it's listening and understanding that the doctor is essentially, let's say, ordering a lab test, so that when the doctor is done with the visit, when the doctor walks out, a phlebotomist walks in. There's no typing, writing, transcribing, handing it from one person to another, generating a document somewhere that a person has to read and translate. It literally understands the natural way that I'm talking about a lab test. It learns about how I talk about a lab test, and it prompts the phlebotomist and prepares them so they can walk right in behind me and take the specimen that's necessary. That workflow evoking activity is part of the value of the structured world. So that's the benefit. That's one kind of ambient technology we can benefit from. The second part of it is embedding technology in physical material. A great example is nanofabrics. Nanofabrics have been around for a while. We started to see them in athletics, but we're now seeing them in healthcare. Neonatal intensive care unit. There are fabrics that exist today that you can swaddle a neonate with. It has two benefits. One, it actually has technology that is sensing technology, heart rate, respiratory rate, temperature. But the second is it has technology that can change the characteristics of the fabric, cool it, heat it, other sorts of things that are part of what you want that fabric to do. So it's not just a sensor, it's actually reconforming the fabric to accomplish a therapeutic purpose. That's the kind of world that a programmable world is bringing us. So we have the second trend, the programmable world, which is really about technology that's always around, serving our needs without us acting on it, and serving our needs in the physical and through physical material that we interact with. The third trend, which we call the unreal, is very closely linked to the concept of Internet of Ownership. I describe the Internet of Ownership as being able to give us the capacity to reliably transact things in a digital world. But to do that, we need to know that we can act on it. That means we need to know that it came from something we can trust and that we have the right to act on it. Very simple example that predates metaverse is part of digital currency and is a critical enabler of what will be in the metaverse is the history behind digital currency and cryptocurrency. And just to restate that so everybody understands it in plain English, what we were solving for was the paper dollar bill problem. And in real world, analog world, when somebody gives you a dollar bill, you don't know anything about that person, who they are, or where they got it from. But yet you can take that currency and give it to somebody else who will accept it as a dollar of value. They don't know anything about you or where you got that information, where you got that bill from, but they can still act on it. That bill has intrinsic characteristics that allow us to act on it. And that was really what we tried to do in digital currency, because it's not just going back to your bank account and figuring out whether you have the money. It's really just saying, I'm presenting you with a digital item that you can act on. You don't need anything more. In that item is all the information you need. Now in healthcare, we have a few pieces that go into this. One of them is, can I act on it because it's trustworthy? But we also have the issue of consent going on in healthcare, because a lot of personal healthcare information fundamentally, while it might be valid, may not be actionable if you don't have the right to act on it. And how do we communicate that right now? Well, in fact, what happens is one of us gives our data to some actor. They put it in their digital application. And then if they want to pass it on, they have to pass on our intent, as opposed to having that intent being connected directly in the information. In fact, what's happening right now is a rethinking of the way the internet is going to work. This is often described as Web 3, not Web 3.0, but Web 3, which is a change in the way the internet works, from us giving our data to applications to us being in continuous possession of our own data, and the applications are coming to us to get the data that they need only for the purposes that we want them to use it for. It's a very different world than the world that we're thinking about now. And this is really you can see the importance of it when we think about personal healthcare information, where we're always worried about us, who do we give our data to do and what are they going to do with it? In the future world, we don't have to worry about that, because essentially those applications are accessing our information only on our own terms. They would have no capacity to share that with anybody else. And if they did, it would have intrinsic characteristics that would allow that next person to know that they have the right to act on that information and that it's reliable. Now, at a larger scale, what's happening in general in the digital world is not only do we have primary data, but we have synthetic data. Data is assembled to create something new. That's essentially what a deep fake is, right? We've taken digital images, we've superimposed them, and we've created a new picture of Tom Cruise talking about something that goes viral, which looks like Tom Cruise and sounds like Tom Cruise, but it's completely digital and synthetic. How do we know if we can rely on that? Because we're not going to be able to prevent that from happening. What we're hoping and what we expect happens in the future is that essentially the digital inputs have attributes of authenticity, so that if I saw an image of me giving a talk, it would be knowable whether or not that was an authorized version of me giving a talk, even if it's a synthetic one versus not authorized, because the actual digital elements that went into it themselves have authenticity. The concept of a non-fungible token, the ability to look at a digital asset, a picture, a word, a document, and know that that is something that I can rely on because it's authenticated. And if I don't see that, call it authenticity marker, that I know that I may or may not want to rely on it. You know, I don't know whether or not someone took a picture of that and shared it, or whether that came from the source. But the concept of tokens, non-fungible tokens, what gives us the ability to live in this world where synthetic data is created, but not worry about whether or not that is a fake or not, because we will know because of the inputs have identifiable elements. So that's trend 3. And then trend 4 is what we call computing the impossible. This is another interesting concept, because what it's saying is that we are entering into a world where the level of computing power that we need far exceeds the level of computing power that we traditionally have had at our disposal. Fortunately, we have technology that it's allowing us to be able to take advantage of that. Where we're going to see this really become an issue for us in healthcare is in artificial intelligence, particularly artificial intelligence that is used for scenario planning or physical robots. What's happened with artificial intelligence, not just in healthcare, but across all of society, is that the deep learning and the machine learning models that existed in the last half a decade were largely based on taking large amounts of data, labeling it, and then training models to be able to reproduce the result of what they learned in the labeled data. And that seemed like the best way to solve the problem. But what we realized is that you almost need an impossible amount of data in order to be able to get these technologies to be reliable enough. So, simple example, but trying to train a computer to recognize a picture of a cat is actually pretty hard. And it takes a lot of pictures of a cat and it still doesn't get it right. And the computer scientists and the AI scientists ask the question, how is it that a child can learn what a cat looks like by looking at 1 or 2 pictures? And so we have shifted the model of artificial intelligence to models that try to replicate the way the brain learns, which is with smaller amounts of data, but larger amounts of computational power, more parametric changes in single variables, running lots of computations. The kinds of artificial intelligence computational power we need now are things that might include the power of 100 million laptops in order to get to an answer. That is causing us to need high performance computing, biocomputing, quantum computing as the enablers for this technology. And what we're going to discover is we're going to need these kinds of tools because they're going to take over human tasks. These physical robots that can actually substitute for human physical tasks, whether it's the shop floor or maybe eventually the hospital floor, are going to require a level of computing and processing that is not what is currently available. It's going to require these new forms of computing. Fortunately, we have the computing to keep up with the artificial intelligence models that are being deployed. So we're going to see the chicken and egg of the hardware and the software keeping up with the needs so that we can really take advantage of technology that begins to substitute for human labor, substitute for human tasks that are non-routine, which is really where we begin to get the ability to scale our precious human resources in healthcare. So we have 4 trends. When you take the 4 trends together, 4 kinds of technologies, you can begin to see how we can get to the Internet of Ownership and Internet of Place. And collectively, that all represents the metaverse continuum. The last point I want to make before we get to a conversation, hopefully we'll be able to have one, is that the current dialogue around metaverse is mostly around things that are felt by consumers, whether it's through entertainment or retail. And that's where you see Meta, for example, doing most of its engagement, where you see a lot of Microsoft applications. But our view is that these things are going to matter just as much in not only how products are made, but how employees experience work, supply chain, and really how the back office runs. In fact, if you ask me, where are some of the best opportunities for healthcare to benefit from metaverse continuum technologies, I'd say two places. One of them is going to be what we started to describe, which is changing the nature of how patients can understand and experience healthcare. But that experience isn't just going to be for patients. That experience is also going to be to train teams. We already know this is the case. If I want to train a team to use a new surgical piece of equipment, today, I generally speaking they read about things and then I get them to convene in a physical lab and they practice. That has capacity, that has constraints in terms of its scalability. I can start to think about, how do I train whole teams, taking advantage of the fact that people don't have to be in the same room or in the same room at the same time, and can have an immersive experience that is likely to give them a higher level of retention. And I can begin to think about getting a different kind of clinical outcome. That's similar to what we're starting to see on the employee experience side, which is a recognition that because of the demand for critical skills and the limited supply in the market, we have to bring people into our organization and onboard them very quickly. And the traditional ways of training and onboarding simply don't work effectively or fast enough. And so we're going to have to start to take advantage of these new ways of training people. And that's going to change the employee experience. That's likely to get them to not only be able to work sooner, but feel more confident of the job that they're engaged in, and potentially get some time back that they can then reuse to make their own lives better, or to make that work experience better for them. So we think there's going to be a significant employee experience in addition to training teams for better clinical outcomes. And then when you start thinking about things like, how does the organization work, enterprise management, maybe we may not be talking about direct patient care, but everything from the physical experience of housekeeping and food service and all of these sorts of things that are going to take advantage of self-service and robotic technologies that are really advanced. All of these are going to have aspects of the metaverse continuum be embedded in part of how they work. So healthcare is going to be able to take advantage of the full spectrum of utilities of metaverse technologies. It won't just be what we now consider to be the traditional consumer side of the healthcare world. So with that, what I'd like to do is end this part of the conversation and see if we can try to move into a little bit of a dialogue. I know this is very complicated, and part of the issue here is this is designed to describe a picture that's a decade or more in duration. This is not about going out and buying something that's for sale today. This is about taking an organization on a journey. And we often have discussions about where do we start and how do we learn. These are all useful conversations, but let me just pause here and see if, Aisha, is it possible for us to take some questions from the audience and maybe unmute people and let them ask questions?
Yes, Kaveh, we can do that. And we now have Kim Schwartz, who's joined us as well. So welcome, Kim. And Kaveh, Kim's going to help you navigate that process.
All right.
Thanks, Aisha. Thanks, everyone, for joining tonight for what I think is a pretty exciting topic. My name's Kim Schwartz. I am an Ignite member and also a managing director at Accenture, where I lead our healthcare technology practice in the South. And so if anyone who has a question for Kaveh could raise their hand, that would be awesome.
I see Mary Hill has a question. Can we take Mary off mute?
Yes, I'm going to.
Hi, Mary.
Hi, Kaveh, can you hear me?
I can. Hi, how are you?
Great, how are you?
Good.
Hey, Kaveh, what kind of organizations would you see being the first ones to adapt this kind of technology?
Yeah, great question. So there are two things that you typically see as foundational issues that help you figure out who's going to go first. One is an organization that has, let's call it an operating model capability for these kinds of things, because these tend to be complicated use cases that involve not only technology, but changes in the way work is done. So there has to be the right kind of an operating place. It can't just be done by IT. It really needs to be embedded in operations. So organizations that have really thought that through are the first ones to take advantage of it. The second one is that you have to have a reasonable digital foundation. And I will say in healthcare, there are sort of two salient markers for me that make me get a sense of whether an organization is on the right path, for advanced enough digitally. The first is the recognition that when I'm talking about technology for healthcare delivery, I'm not just talking about the EMR. In many organizations, if I were to go to the leadership and I'd say, what's your technology strategy? They talk to me about EMR. I'm talking about technologies that are far beyond or distinct from EMR, electronic health records. The second issue is when I say data, I'm not talking about patient data. I'm talking about all kinds of data sources. For example, simple example, but every organization in the world has badging technology. You badge through doors all the time. My guess is in most organizations, that's never been considered a data asset that sits under any kind of governance. It's probably data that sits, in many cases, it's thrown away. It sits in some server somewhere, never used. You go over to the hospitality industry, if anyone is uses a Marriott or a Bonvoy hotel, they're tracking and building profiles based on a combination of the characteristics of their customer and their badging behavior to try to figure out what kind of customers come in at what time and who uses what services and at what frequency and when they start. That's all stuff we could do, but we would have to understand that what we're talking about in a healthcare environment around data is not just clinical patient data, but it's data about things and people and equipment and all those sorts of things. And the data governance and the data management is that totality of all those things. So looking for those, that operational and that technology pieces are what really tells us who's going to go first. And it's not about size. It's not about money. It's really about mindset.
So do you see it being an organization like, you know, a Baylor Health System or, you know, a Kaiser or, you know, something like that that's got to lead that parade? Is it got to be
yeah,
that
it's a great
cohesive?
question. So that's the reason I made the point is I don't think it's about the organization's size or name. I think it's about these kind of characteristics. And I'm less worried about whether it's big or small, but more about how does it get to an endpoint and prove efficacy. Because right now what we really need are people to actually prove efficacy, because that's what's going to inspire others to follow behind it. So in many cases, it could be, you know, it could be a much smaller organization with much less of a footprint because they have the right kind of leadership and the nimbleness to go first. I don't think that things like being an integrated delivery system or a payment model have to be required. In some cases they are, but that's less important than whether or not they really have some of these foundational mindsets in place.
And the technology.
Yes, and the technology. Robin, I think that or I saw Robin Brown has a question.
Yes, thanks, Kavi. And thanks for doing this. We're always trying to figure out what the next is, right? Since Accenture has their toe in other areas other than healthcare,
Mm-hmm.
you know, I think digitizing the way we do things and being a little more interactive is really about the infrastructure. And I don't know how you guys are working or have insight in, you know, Wi-Fi accessibility and cellular, and because I've spent the last 28 years roaming around interesting spots in hospitals that you couldn't get a cell signal in that hospital corner if you tried. So what's the plan to advise folks that want to jump in here with both feet and get the support they need?
So one of the core technologies that is going to be critical, a critical enabler for this is 5G. And 5G is actually a we have a 5G center of excellence in an area of focus for 5G that is about all industries have to take advantage of it, because 5G allows a level of data movement, both speed and heterogeneity and size that is not accomplished through any of the current previous G generations, right? And it changes, for example, I'll give you I'll illustrate the significance of this because it changes the way we think about things. So, for example, traditional electronic health record, you had to be connected to get utility, right? Because you had to go back and interrogate a reference database somewhere. It wasn't you had a terminal or a pad, but at the end of the day, all the stuff you needed was somewhere back in a data center. And so if I couldn't get connectivity, I couldn't use the electronic health record. Well, the way 5G is designed, you combine that with edge computing so that the device can have both a lot of memory and processing power at the edge. And you don't actually have to go back. What you can do, and you can imagine a situation where I know all the patients I'm going to see in the next 4 hours. And I can, in a physical 5G space, almost instantaneously bring all of that information onto the device that I'm going to go. So I don't know what I'm going to need, but I have everything. And I have the computational ability that I'm going to need locally. And so I can be off grid with my smart device. And as soon as I walk into a node where I'm back on grid again, it synchronizes. So I don't need connectivity anymore. This is really becoming interesting in dealing with digital divide and people who have access issues, because what we've discovered is we will never get connectivity to every citizen. But if we can take a human being, give them a smart device, and give them 5G connectivity at certain endpoints, they can physically walk in and start to become frontline healthcare workers in areas where services are completely remote. So big emphasis around that as an enabling network technology is really true across all industries. Right now, most of the 5G is happening in adoption is happening in manufacturing, warehouses, and natural resources where dangerous jobs are occurring, all of which have a critical need to take advantage of these technologies. Many of them are where you're also seeing the first deployment of metaverse technology. The computational power that we need is also changing things, because it means that you're going to have to decide how much of the computational power is done locally and how much of it is done at a distance. That's going to take some architecting to think through. But those are all things that are 5G and edge combined are really very technology critical requirements here. It's one of the reasons why what we're telling people, leaders now, as they think about their leadership team. This goes back to a statement I made to the question that Mary asked, which is this whole leadership issue and mindset issue. Is I'll often say, you need in the room as you make strategy a technology leader who's thinking about technology through the lens of strategy, because you won't even have any idea about what's possible unless somebody tells you what's possible. And that's going to potentially change what you think 5 years and 10 years looks for. So you set a different direction. Otherwise, you're going to set a very modest endpoint because you won't even conceive of this as being possible. So I'm encouraging people to start rethinking what technology leadership is and bring them into the conversations for the purposes of strategy to accomplish this issue and make sure we ask the right questions. Maybe a long answer to a short question.
No, thank you very much. Appreciate it.
Cheryl?
Kaveh, it looks like Cheryl Stavens has a question.
Yep. Hi, Cheryl. Cheryl, if you're there, or have unmuted her.
She's unmuted, but she may be still on mute herself.
Okay. Hey, I see my
Maybe
friend.
we can go to Molly.
Molly. Hello, Molly. How are you?
Going.
Molly, are you off mute?
This is Cheryl. I can go.
Oh, go ahead, Cheryl. Go ahead, Cheryl. Cheryl first and then Molly.
Okay. I know you said it isn't about money, but in healthcare organizations, it's always about money. When we started with the EMR, I'm old enough to remember when we first started talking about an EMR, it was always about how it was going to save us money, which it never really did.
Right.
How do you address organizations when they really think about this, about the financial side and the cost of healthcare in general and what it's going to do?
Yeah. Well, so pretty important point. Business cases are always important. This is a thing that requires investment. What we realize very quickly is we're talking about longer term transformations, which means the period of investment is longer. There's more investment upfront and the returns are later on. But more importantly, the measure of return is not traditional. We have to think about this through different lens, because in fact, what we're going to do is, for example, we're going to begin to solve for the problem of no people to do the work, which is different than how do I do the work more cost effectively. And that's a really interesting one. I recently did a presentation around the future of work and how technology is going to take over tasks from human beings and what that journey looks like to a group of CFOs. And the question we put on the table was, how do you think about this through the lens of business case? And a number of very large health system CFOs that you would know or have heard of said, you know what, this is not a traditional question that you apply a traditional, hurdle rate to. This is an existential issue for us, because without it, we're not in business at all. So we have to take a different view of what return means, what the horizons mean. But what that does require is real belief and conviction by the leaders. They have to actually believe that this is a critical, essential part. If they think this is optional and they're looking for a traditional business case, it's never going to happen. But I think the pressure is going to come, and it's going to be driven by the lack of people to do the work. And we're going to feel it in a very different way. We're not going to feel it because people are asking us how to make our margins different or how to make our care less expensive. People are going to be frankly not getting service because there's not enough people providing services for the demand. That's going to create a very different kind of pressure for investment.
So Kaveh, I'm back on now. Is it okay to go ahead?
Yeah. This is Molly.
Yeah. Yeah.
Hey,
Good
Molly.
to see, very nice, very good to see you. And this has been
You too.
fascinating. And my question really follows on the last one. Some others on the phone, or you may remember, but just yesterday, I think there was, or the day before, a survey out that said more than half of healthcare CEOs, CXOs surveyed said that they would be doing their roadmap, their digital strategy 5 years from now. And, my heart sank, even if I sort of knew the pattern existed. And so what my real question for you is, what corners or subsectors of the industry do you think are going to move fastest on this? Because even the old distinction, are they risk-based reimbursement or not, is still pretty marginal, given the conversation you just had is not something that's really native to most of the leadership in the industry.
So great question. I'll tell you my own current opinion, which is that and this gets back to what I just said. I think the forcing function is a labor shortage. It's rooted in the reality that there's just not enough people to do the work. We cannot train, recruit, or retain enough human beings if you do the math, because the workforce is available is so small now compared to the demand. A fun fact to put this in perspective: if you look at the cohort that is 60 to 80 years old, and then you compare the cohort of Americans that are 40 to 60 years old, so think of that as a big part of our healthcare workforce, there's 26% fewer people in that cohort. And every time somebody leaves the workforce in healthcare because they retire out, they don't just leave the workforce, they flip over to the patient side of the ledger. So we're starting to see and expect to see pretty stark shortages in access. And that's going to be a completely different kind of forcing function in terms of how people are going to respond. And it's going to be most felt where there's a high dependency on human beings. So I'm thinking about, I'm going to put it in air quotes, but the more nursing dependent, the more critical the problem is. Physicians are one thing, but the nursing services, from high-end nurses all the way to low-end nurses or even nurses' aides, physical activity of daily living, that's where we're really going to feel it. So I actually think the inpatient and the acute care side is going to feel the crisis much more than, say, primary care will or ambulatory care. I think the home care side, because of the need for physical resources in the home for people who simply cannot get out, you can't solve for that problem without sending caregivers to the home. And we don't have them. So what are we going to do? Those are going to be much bigger forcing functions. And that's where I would look for adoption first, rather than, I'm not really so much thinking that primary care is an issue or ambulatory care is an issue, because I think we have technologies and self-service things that can solve for that. But where you absolutely need a human being and you cannot substitute for a human being without really thinking hard about how technology takes tasks over and reallocating work, that's where it's really going to be critical. That may be unorthodox, but that's my view right now.
Well, as you may know, I'm on the board of a home health and hospice company, and I can totally believe your description of the pressures. That's certainly very real and very, very acute. But at the same time, the ability to implement this, I mean, we're seeing it that even the most advanced efforts in hospital systems, you know, look at what's happened with Olive, for example. That the ability to actually put this together in a comprehensive strategy where you're having to work with multiple vendors, et cetera, is really a challenge beyond the scope of an awful lot of provider systems or plans.
So totally agree with you, Molly. And what I would say to you is that this is a classic challenge of a complex adaptive system. It's designed to stay in homeostasis, right? Change is really hard. The other thing we know about complex systems is that they really only respond to severe external pressure. They don't really change on their own. I think about COVID as a great example, right? The pandemic forced behaviors that hospitals frankly couldn't do before, and many of them stopped doing as soon as the pressure got let off. So in my mind, the question is, do we have a forcing function that's going to be so catastrophic that it's going to actually create a realignment? And that was what I was hypothesizing, is I don't think we've had one, but we might. And if we do, that's where we're going to feel it first.
Okay, thank you.
Mary, do you have a follow-up question? I see your hand still up.
Okay, I think I'm unmuted now.
Yeah.
Yeah. So if I look at, and I'm going a little more tactical on here, so you can not answer if you want, but
Okay.
If I look at, like, in Dallas, because I think we're a Dallas audience here, Texas Health Resources does something now that, in an urgent care setting, but, basically they, have the pharmacy kiosk, and, if you need an x-ray, they, query out to the radiologist somewhere that reads the x-ray. And, it's a lesser, it's a lot of service, but I think it's a lesser probably amount of healthcare service that is required, or the touch that you're talking about, maybe. So do you see it as potentially funding, I guess, the human resource through reducing the care maybe in primary care to go into these more acute settings? Do you think that's the way the industry might
So your question
approach
is,
it?
where's the money going to come from, right?
Well, it's the money, but it's also, listening to you talk about the people part of it. The people got to come from somewhere. And
Well, so great question. So let's talk about that first, and then we talk a little bit about the money. My particular sense is that we're not going to, we don't solve the problem by moving people from one thing to another.
Okay.
What's actually happening now, and we're working with a few organizations that are doing this, they're looking at the tasks that people are doing, and they're actually scoring them. Which are the tasks that are being done by my people today that can be done by someone else in a different labor pool that's more accessible? That's a set of tasks. Second set, what are the tasks that are being done today that can be done by technology that's cognitive? Third, what are the technology services that are being done by people today that can be done by technology that's physical? In that first one, most of the first actions are happening by saying, okay, if I looked at the tasks that are being done by people who I have in short supply, let's call it nurses, there's a bunch of stuff that can be done, but maybe by a lower level, but still credentialed person. And then there's a bunch of stuff that can be done by nurses, but they don't have to be physically located here. So I can actually access a distant labor pool, another city, another state, another country. We can solve for licensure. We are right now, Accenture has a couple thousand nurses in the Philippines that are licensed at state by state level in the US, doing voice functions that nurses do in certain cases. Then the third thing is, can I go and use a gig economy? And I'm not talking about the traditional concept of traveling nurse. The traveling nurse experience that we're having now is not really a gig economy. What it is a failure of the market to understand what the equilibrium price is for nurses. And so you get into silly behaviors, which is, instead of raising my nurse's salary by by 50% to keep them. I refuse to, so they quit, and then I have to rehire them at 100%. But they wouldn't have done it if I just raised it by 50%. But at some point, the market's going to figure that out. The gig economy is based on something different. It's based on taking advantage of the fact that there are only certain times that I need a certain supply, or a certain time where I need a certain skill. And there are people who only want who want to work in those kind of environments. So let me give you an example of of a gig question we haven't figured out correctly, but other industries have. One of the things that gig markets like, let's call it Uber, have figured out is that when people actually step into the spot market for work, they want to get rewarded immediately for the work they do, like literally immediately, on the spot, money in the bank account. There's a company right now that's focusing on nurse gig. And this is not about wages. This is about the fact that they've recognized that there are nurses who decide to work extra shifts as long as they get paid that day. The money's in their bank account when they go home. We can do that, but we don't, because we have these crazy payroll models that have 2-week and 4-week latencies in them. But they're just saying, can I just get, if you could pay me so I could go do the thing I wanted to do, I want to work extra this week so I can go buy this thing on Saturday. If we could just figure out how to pay them, they would work. That's the kind of complex thinking about gig economy and motivating gig workers that we'll start to see unleashed. So I think you start organizing the task, then you take advantage of what are the models that give us access to new labor pools, different labor pools for different reasons. And then eventually you go to tech.
My follow-up question to that is, it seems that, at least in this model I was just describing, it's hard for me to tell how they're getting paid exactly, though I'm pretty good at how people get paid normally. And so I wonder if that's part of this gig or this, model you're talking about is,
when you say actually get paid, what are you talking about?
I mean for the service. So
well, think of these
from Medicare, from whatever, not the nurse getting paid, but
well, these are structural costs to serve. They won't generate any revenue if they don't have people to provide the services. So this is no different than you don't get paid to add a nurse, you get paid to provide a service. The nurse is just the question is, how will I provide the nurse? Not will I get paid for a nurse? You're not going to get paid for that episode if you don't have a nurse. That bed will sit empty.
I had moved on to more the administrative side, but that's okay. I'll let that go.
All right.
Well, I hate to break in on such a fantastic conversation. Kaveh, thank you.
My pleasure.
For sharing this incredible information, and to all of you for the questions that you've asked that have continued to help us learn and grow from the varied questions. As I'm looking at all of this, what I'm seeing is the incredible pace of tech advancement and its possibilities that Kaveh shared with us, which is just, in some cases, mind-boggling. At the same time, there are the realities of what adoption looks like and what is the pace of adoption, what are the catalysts. And at the end of the conversation, we are talking about the labor issue, which seems to be the #1 topic everywhere. So is that really the primary force to catalyze adoption for some of these things? What I'm left also wondering is, there are traditional organizations, healthcare payers, providers. There are also the new entrants like Amazon that may move more quickly, that are more agile from a technology perspective. And how do they impact the adoption of these kinds of technologies? But you leave us thinking with a lot of great information. So thank you for this evening, and thank you everyone for joining us.
My pleasure. Nice to see all of you. Take care. Have a good evening.
Thank you. Thank you,
Bye.
Kim. Bye-bye.